Welcome back everybody to another video. This time it's a cataract case, but it's mixed in with a corneal ulcer just to keep it interesting. So what we can observe here, aside from the white intumescent cataract, is the fact that the patient has some nylon stitches on the cornea, and there's some mucus strands on some of them, and an old healed inferior corneal ulcer that's almost encroaching on the visual axis. So the history of this case, while we let the trypan blue stain the capsule, is that this patient had presented to our ER department 1 year ago for a corneal ulcer, a spontaneous one with no prior history, which was managed successfully, and then the patient was sent off to rheumatology for assessment. Nothing was found on initial workup. The patient was discharged, and he underwent no further treatment or follow-ups for the better part of a year. Recently, he presents to us again for the same pathology in the same eye, same location. So the ulcer has reopened, it's wider, it's deeper, and it's threatening perforation. So what we do is we take the patient up for surgery with a crescentic lamellar graft, which it's a subject for another video, but that surgery went well, and the patient was again sent for rheumatology and parasitic infections and more extensive workup than the first time. And frustratingly, nothing was found this time either, except for some herpetic antibodies, which we didn't deem to be related to his ulcer. And after that, the patient also underwent an amniotic membrane because the crescentic graft itself starting to ulcerate. And because of the perforation and the complications and the dexamethasone that the patient was putting in his eye, he develops this intumescent cataract, which now has become quite of an emergency because of IOP spiking. The case itself, in terms of surgical procedure for a cataract, is no different from any other white cataract. The only thing you should be wary about is the fact that the site of the ulcer is a very weak point, and if possible, you should be using phaco machines that have low IOP settings, which in our case is the Alcon machine, which has titratable IOP, and you can work in the high 20s or low 30s regimes without risking dehiscing the graft, or even in cases of non-grafted eyes, maybe corneal wounds, sutures in the eye, those will stay closed if the IOP doesn't rise too much as you would have in gravitationally based systems. In terms of other specifics of the surgery, I wouldn't have anything to add. You would do your case like normally. If you see that there's intumescence in the lens and there's risk of rhexis runout, you would do your double helix, double contour rhexis filled with OVD, aspirating, whatever technique you want. There are many other videos on YouTube about ways of doing rhexis in intumescent cases. So I'm going to forward the video a bit. Here we're starting the phaco chop technique, which in these cases of white chalky nuclei are a joy to do because cracking is very easy. The red reflex isn't there at the beginning, but after you take a quadrant out, it starts to appear, and there's very low risk of breaking the capsule because there's extremely high contrast between what is the cataract and what is not. And in these cases, posterior capsule rupture can only occur if the surge is uncontrolled or unaccounted for, which is not the case here. So performing our usual technique, we emulsify all the bits and pieces of the cataract. There's not much cortex to speak of, and the rest of the case goes uneventfully. And the type of IOL injected in this case is a preloaded monofocal single piece acrylic, simply because we did not expect to have any capsular complications, and if we had, we would have probably exchanged the lens for a 3-piece one. Otherwise, the post-operative course of the patient was unremarkable, the same as for any other cataract case. And we're still following up for maybe finding out the etiology of the ulcer. Thank you for watching.